I have protected the left side of my screen. I'm going to be talking about insulin futures, as you say, and it's a pleasure to be back talking about the future of insulin therapy, the future of insulin therapy into, of course, its second century. This is quite a big talk. I've got quite a lot to say, so I'll get on fairly quickly. Just to note that I do not have any dualities of interest for the products. I'm going to talk about the potential products, but I do, of course, for the comparators which are on the market already. So let's think about what we might talk about here. And first of all, what I'm not going to talk about, there are areas in insulin therapy such as prevention, such as insulin regimens and education materials, transplantation technology, islets and regenerative medicine, gene therapy and closed loop systems. These are not the things I'm going to talk about. I'm going to be talking about insulin itself and getting insulin into our patients to their benefit. So the things at the bottom here are the subject of my current talk. We need, however, to think about what we're trying to achieve, and some of the problems we have for insulin have to be overcome. And in particular, minute-to-minute regulation to govern changing need, eating, exercise, and the like, hour-to-hour regulation to changing need, post-exercise, post-hypoglycemia, concomitant illness, overall calorie intake. We need a flat basal insulin level, except in the post-absorptive state, and we need a fast and reflex incretin response to calorie consumption, not regulated by glucose. But glucose and amino acid regulation, of course, after a meal. And presently for insulin, except for basal insulin therapy, perhaps, we are unable to provide any of these with current insulin therapy. As a result, no one with type 1 diabetes attains normoglycemia, 4 to 7.5 millimoles per litre, and average daily plasma glucose based on HbA1c in type 1 diabetes is about 50% above normal. Here's what we need for basal insulin delivery. As I've said already, here is the glucose under flat control during the night, and here's how it's achieved with feedback and absolutely flat basal insulin delivery. This is the case with normoglycemia. If you have people who are even mildly hyperglycemic, there are changes during the night. Then we have the mealtime profile. Mealtime insulin delivery, a sharp rise, 50%, 60% increase in just 15 minutes in insulin concentrations to a peak at 30 minutes and beyond, and declining, and this regulated by glucose to baseline at 4 hours. So we're looking at a flat profile and a sharp, indeed, upward profile driven by incretins, driven by reflexes and regulation on the way down, but all this regulated on a minute-to-minute basis according to need. If I was to leave this computer now and run out to the road outside, run back again and sit down, my insulin secretion will have fallen by about 50%. It's very rapidly regulated in response to calorie intake, physical activity, and indeed acute stress. And that, of course, can't happen once you've given an insulin depot. That's also true for basal insulins. In a few hours, post-hypoglycemia, with development of concomitant illness, taking alcohol with some medications, or increase in overall calorie intake, we will see a change in insulin need in no time at all. And these things somehow we need to get into our insulin preparations in the coming future. I'm not going to talk about closed loop, but you might say to me, well, what about closed loop? Well, here's a state-of-the-art a figure taken from a review in Diabetologia only a couple of months ago. Just look at the basal insulin delivery. It's a series of little humps. It's not flat at all during the night. And this is classic feedback over control with oscillation, and it occurs by the need to sense glucose subcutaneously rather than the circulation, and to deliver insulin from subcutaneous tissue rather than intravenously. So no, we can't do it with closed loop systems either. So first of all, let us look at micro and nanotechnologies. And this section will be fairly brief. Actually, they're long familiar in diabetes. They're not particularly new. The insulin hexamer itself, of course, which we inject in our regular preparations, is 5 nanometers in diameter, and the insulin analogues, which are developed from meals, dimers, and monomers, are about half that. So we've engineered down to about 2.5 nanometers to enhance diffusion and capillary wall permutation. Insulin degludec, it forms multi-hexamers subcutaneous weeks, a whole month. We can see the insulin profile, and I calculate from this that the half-time absorption is around 2.5 to 3 weeks. So despite the peak, which would of course end when you give the next injection after 7 days, you probably get quite a low peak to trough ratio. And they suggest a peak to trough of 1.1 after steady state injection over 6 weeks. Although I would have liked to have seen this data at 2 and 3 days, because I suspect it's worse at the 3rd day than the 4th. But this shows some promise, and this insulin now, we're waiting phase 2 data, I think, at the upcoming ADA meeting later this month, and I expect it then to progress into phase 3. Novo Nordisk potentially have a bigger problem. Here we have again the PK profiles, and you see here the plasma half-life is actually around 1.2 weeks with a maximum time at just 16 hours. So this does give quite a big trough, and it may be cut off on your projection, but the peak trough ratio between, say, a Wednesday and a Sunday would be about 1.4 times, i.e. like giving a dose 40% higher on this day and then at the end of the week after injection. And that really means the insulin wouldn't be suitable at all for use in type 1 diabetes, and I think of questionable use in type 2 diabetes. 3 studies have been published in the last year with icodec, 1 of high quality plus 2 lesser titration studies. Sadly, the comparator in all with insulin glargine, 100 units per mil rather than state-of-the-art insulin degludec. The quality Rosenstock study was double-blind, 6 months, not large. It was a phase 2 study. The HbA1c difference wasn't statistically significant, although it trended in favor of the insulin icodec. But the problem here was that the insulin glargine didn't reach steady state in the last 2 to 3 months of the study, so we're not seeing the full effect of the comparator. For similar reasons, perhaps achievement of target was perhaps slightly better with the icodec. But on the other hand, there was a significant, not statistically, but in safety terms, signal for hypoglycemia based on confirmed clinically significant SMPG of 3.0, of perhaps approaching double. And we've had, unfortunately, no analysis from Rosenstock and colleagues of day 2 versus day 7 data for glucose or hypoglycemia, and clearly that's needed. But this insulin has moved into phase 3, and you can look at the studies. They're listed on clinicaltrials.gov. I wait to see what the results from that will be. So what about two other areas? Firstly, small molecule insulin mimetics, and secondly, glucose responsive smart insulins. Just one slide here. The scientific basis for insulin mimetics ought to be clear. We've known the insulin structure since Hodgkin's work in '69. We've known the insulin receptor study structure now for 18 years. But when I do a literature search earlier this year, no realistic candidates in development. The problems, of course, are that insulin's binding to its receptor are quite complex, with multiple sites of interaction and conformational changes on binding. Further, the time course for receptor occupancy, then internalization, is very short indeed. And insulin, as we know, signals down both metabolic and growth promoting pathways, and the latter might give proliferative risks if receptor binding is prolonged. Further, gut absorption, which is where small molecules will be aimed, will be no faster than subcutaneous absorption and subject to high variability effects from different foods, so doing no better for meals and possibly more erratically absorbed as a basal insulin. Lastly, of course, a small molecule does not solve the problem of feedback control of insulin action, which is so critical to obtaining good glucose control. If we look at glucose responsive insulins, they might be thought to go some way towards that. One approach is to modulate subcutaneous insulin delivery rate according to plasma glucose concentration. And another would be to modulate the activity of circulating insulin once in the circulation by plasma glucose concentration. A big problem is that both of these require a very steep relationship between activity and plasma glucose. I estimate you need to double insulin action in raising glucose by 1.5 millimoles per liter glucose. Taylor and DeMarchi estimated that you need to increase insulin action 10 times between 2.5 millimoles per liter and 8 millimoles per liter. And these dose response curves are about 3 times steeper than a conventional enzyme kinetics. So they look more or less unobtainable. Furthermore, neither approach can begin to emulate, of course, the reflex and increasing stimulated delivery of mealtime insulin, which about 70%, 80% is not related to glucose concentration. However, it might be that a basal insulin whose action halved perhaps between 10 and 5 millimole per liter would significantly reduce hypoglycemia, if not attain normoglycemia. Either approach needs to sense glucose, i.e. to bind it in a concentration-dependent manner. Back in, 40 years ago, Brownlee and Sarami proposed that using lectins to bind glucose to disrupt a polymer containing insulin, either in subcutaneous tissue or the gut wall, could be a way forward. Others have suggested glucose oxidase may be used more specifically for glucose, that when it's metabolized glucose creates glucuronic acid, as in glucose sensors, decreasing pH, and that can be used to accelerate the release of aliphatic insulin. Then there are the phenylburonic acids, PBA, which bind monosaccharides. Again, binding can be used to disrupt a polymer, releasing insulin from a depot. But there are additional problems, even if the dose response issue can be solved. Lectins are very toxic. Concanavalinase is mitogenic. Glucose oxidase is a fungal protein and will be antigenic. It is not stable in liquid phase. In sensors, it's immobilized in solid phase. The stability of boronates and polymer complexes remains a problem. And lastly, glucose, of course, needs to diffuse into the depot to affect the complex, then into the polymer complex, and then insulin needs to diffuse out and be absorbed into the circulation, creating a feedback loop which would have a half time of something between 1 and 2 hours, not even suitable for a basal insulin if you're going hypoglycemic. Abandoned approaches also include modulation of current extended acting insulins. A patent describes insulin glargine, which of course microprecipitates physiological pH but has enhanced solubility at a more acid pH. So raise the glucose using the glucuronic acid from glucose oxidase, and you might get faster release of the glargine. But really, you're not going to get the dose response curve necessary. Novo have looked at polyols and boronates to interfere with the stability of insulin degludec, like multihexamers. Again, they couldn't get the dose response curve needed to take this forward. Neither approach has the required sensitivity to glucose. So what about other approaches? Well, this one actually got to the state of being investigated in very early phase 1 clinical studies. And it's based on the principle that our macrophages have the ability to express surface lectins, which can detect glycosylated molecules and internalize them very rapidly. This is thought to be a mechanism for internalizing potentially pathogenic bacteria, which have leaked into your circulation. Thus, an insulin bound to a monosaccharide will be similarly removed by high affinity by this lectin pathway. But in the presence of high glucose, as indicated by these blue dots, that pathway will be blocked and insulin will be relatively directed to its receptor. So glucose can compete with the insulin monosaccharide complex, reducing its clearance via the macrophage and increasing insulin concentrations. It is possible to choose a candidate which, despite glycosylation or use of other saccharides, has 20% of the activity of human insulin. That's not a problem. And it's possible to show that if you raise glucose clamp studies, then you do indeed actually raise the concentration of active insulin. But just look at this scale. This is an increase of about 20 or 30% going from glucose of 4 millimoles per litre up to glucose of 15 millimoles per litre. So it's really a very slow, less steep response. A clamp study in people with type 1 diabetes following dog studies showed no glucose-dependent change with the candidate insulin, although there was a significant glucose-dependent augmentation of glucose infusion rate. The project was abandoned and Merck returned the license to the Smart Cell company, which came up with the idea. There are other proposals. Insulin, of course, binds with its receptor with high affinity, as we've suggested. So what if you could use glucose concentration to interfere with insulin shape to reduce binding? Here's insulin active, and here is a hypothetical adult running across part of the binding site of insulin and thus blocking its binding. Here, glucose binds to that adult, shifting it out of the way and activating the insulin again. So that's the principle of high glucose activating the insulin. The problem is you need to, again, find a glucose binding side chain with steep binding kinetics. But further, as insulin is unable to bind to its receptor, as here, what will happen is its concentration will rapidly rise in the circulation. And of course, the higher concentration will overcome the lower affinity. So a feedback loop will occur whereby the blocked insulin is causing more activity again. So this is unlikely to be very successful. Then lastly, I'll move to orally active formulations. Superficially attractive, no injections, taken with food, matched to food. First pass, liver is physiological, of course, but I would point out that we don't want liver preferential insulins. They cause problems, as was demonstrated with peglyspro, in a high-calorie environment. They're profoundly problematic due to insulin digestion, that insulin does not cross epithelia, that food will interfere with absorption profile, and that there's low bioavailability with food interactions and high gut transit. To put this in context, a study recently on semaglutide showed a variability between days of 140% for the oral preparation, which was reduced to 35% by recurrent delivery of the long-acting preparation. That's okay for a GLP-1 RA. It would be hopeless for a mealtime insulin. I'm not going to go through this in the interest of time, just to say there are a variety of approaches to enhancing absorption, protecting from injection, and trying to improve erratic absorption. These include avoiding hepatic over-insulinization. Here are some candidates. Biocon's insulin integrabil has been studied now for over 12 years with intermittent phase 1-2 studies. You can see the profile is an insulin which is absorbed over about 60 to 80 minutes, and that its glucose lowering effect is lost really after about 80 minutes, which means really that this preparation seems ill-matched to prandial or basal insulin needs, and this at a time when GLP-1 RAs are largely replacing prandial insulin. Furthermore, there was interference by a high-fat meal. The Novo Nordisk 338 is an acylated insulin, and not dissimilar to that insulin I showed earlier for the weekly insulin. It has an absorption enhancer and a very long half-life, around a week, with low receptor affinity to try and smooth the erratic absorption. Phase 2 studies for 8 weeks showed glucose control, which actually favored the comparator glargine, and high variability. You can see that here. The confidence intervals in the blue lines are very much bigger than the red line for the insulin glargine. Bioavailability was 2%, and as far as I can see, this insulin has been abandoned by the company. Not abandoned is Oramed, which is now in phase 3, but that has problems too from its phase 2 studies. Here is 32 milligrams. You will see it gives lower effect than did 8 milligrams. How do you explain that? Further, the HbA1c attained was 8.9%, a rather pathetic glucose reduction from what we're used to. And I think this conglomeration of erratic results means this is not going to be a successful candidate in phase 3. So last slide in conclusion. Microenable technologies. These are presently technologies seeking a need. Small molecule insulin mimetics, no prospect of current clinical utility. Smart glucose responsive insulins, attractive, some progress, but no current clinical candidates at present. Orally active insulin formulations, I would predict, are unlikely to reach the market in the near future. which takes us back really to our insulin analogues. There is still a little progress being made with mealtime insulins, and I've no doubt that weekly basal insulins will reach the market, even if they do give inferior glucose control and earn some extra hypoglycemia. I thank you for your attention.